Before we get started, this is part 2 of our conversation. If you haven't listened to part 1 yet, I recommend going back to catch up. Otherwise, let's dive right in. So, are PBMs supposed to be responsible for figuring out what is on a formulary for a certain insurance plan and for negotiating drug pricing for that particular plan?
Yep, so that's a great question. And the short answer is the PBM actually determines the formulary. So when they, to continue the analogy, you can think of like Visa or MasterCard as like being responsible for negotiating the prices at like Walmart and Macy's. Okay, so instead of instead of Walmart and Macy's just setting their prices however they want, it's like the credit card companies went out and like, okay, Walmart, what are you going to charge? And Macy's, what are you going to charge? And also it's like, okay, the formulary is okay, well, there's only certain things that you're going to be able to buy. You're only going to be able to get shoes and this brand of milk and this brand of blankets and this brand of cereal. And so that the PBM is actually negotiating not only the prices, but they're also negotiating what you can or cannot buy from Macy's or Walmart. And in this case, you replace Macy's and Walmart with the pharmaceutical company, Merck or AstraZeneca or Eli Lilly or Pfizer. And so not only is the PBM charging the transaction, but they're using that leverage that they have to be like, okay, if you want to even, let's say Walmart really wants to sell their milk. Be like, okay, fine, Walmart, if you want to sell your milk, like, I don't know, there's lots of other places we could get milk. We could get milk from Kroger. We could get milk from Safeway. Why should we have Walmart milk? And be like, okay, we'll give you a good deal on the milk. We'll sell it to you for X amount. And they're like, okay, but then we need to add on an extra, the milk you're selling for $5 and we're going to add an extra $3 onto that milk in order for you. But like Walmart's like, but we don't want our milk to be expensive. We want to sell our milk for $2 and we want you to only add 50 cents. And they're like, look, if you want to be on our formulary, you're going to sell your milk for $5 and we're going to add $3 to it. And there's going to be $8 milk. And so people are like, well, milk, $8 is a lot of money for milk, right? And so the pharmaceutical companies blame the PBM, being like, look, we wanted to sell the milk for $2, but you wouldn't let us sell the milk for $2 because you wanted to jack up the price and take $3 for yourself. So there's a whole bunch of finger pointing, okay? Now, the pharmaceutical companies, again, they absolutely will charge, thousands of dollars for medications that only cost pennies to make. And the PBM will absolutely ratchet up the additional cost that the medication will have because they're adding that transaction fee on top of it. And so when you put the two together, there is coupability to go around.
Do you happen to know, and you may not, but what the cost to make Ozempic or Mounjaro is?
Well, to a certain extent, you can use the compounding prices as a proxy, but it is single-digit dollar amounts, if not lower. And the pharmaceutical companies freely admit this. They're like, look, it's not expensive to make, but what they say is that we have huge sunk costs in the research and development of the medication. So yes, it might be super inexpensive to manufacture. And so the marginal cost to create an extra vial of Ozempic might be very low. However, we are justified in charging these huge amounts in order to recoup the research and development that we did. And so that, we're not here to answer that question today. And I think the sort of poster child for this is like rare orphan disease drugs, like for things like cystic fibrosis, where it's hundreds of thousands of dollars a year to treat a person with cystic fibrosis, or some cancer treatments for brain cancer are literally $500,000 a year. And of course, it doesn't cost $500,000 to make that medication. And to what extent is it extortion on the part of the pharmaceutical company? And to what extent is it them, quote unquote, advancing medical research through this money that they're making? And the short answer is that's a highly controversial topic.
Yeah. And, I think like everything, it's nuanced too, because with great good can also come evil or taking advantage of a position of power too. So it probably isn't a black and white answer, which does make it a bit challenging. So based on the data you've seen, have PBMs, and especially when PBMs were bought and taken over by United Healthcare, Aetna, CVS, etc., has that led to an increase in the cost of medications or a decrease in cost of medications?
Yeah, so it's a good question. And the short answer is it depends upon who you talk to. I'm of the opinion that it has overall, it has raised the cost of medications. And here's the reason why. It's because the negotiation and the pricing between the pharmaceutical company and the PBM, it's kept secret, okay? And so the secrecy around that pricing is not done in a way to keep the price down. It's done in a way to keep the price up. And so at the end of the day, anytime there is secrecy anywhere, remember JFK in one of his speeches said, we abhor secrecy, because typically if there's secrecy, it means that the public or patients or the government or employers or who's paying for this is being taken advantage of, right? So like I used to live in Chicago, and on the L in Chicago, there are like scammers, okay? And the scammer is not transparent in how they are scamming you. It's a secret, okay? And so anytime there's, so the famous quote from Justice Brandeis is that sunlight is the best disinfectant, which metaphorically speaking means the best way to do the most good for people is to make things transparent, because in the shadows is where bad things happen. So listen, it's America. It's a free country. Pharmaceutical company and PBM, you guys negotiate whatever you want, but it needs to be transparent, especially when you have the government, which is accountable to the American people, paying for this. So ultimately, the people need to hold the government accountable so that the government can hold the PBM and the pharmaceutical companies accountable. Now, of course, there's lots of obfuscation that goes along in there, but ultimately that's the right thing to do, in my opinion.
Transparency is so important because it enhances competition and it lets people know what is actually going on. Stacey Richter, who is the host of the Relentless Health podcast, uses that quote all the time. And I think it's so true in so many industries, especially the healthcare industry. Would you tell us how copay cards work? Because I think part of the lack of transparency is with patients, because patients are like, oh, well, this is covered by my insurance, or this is, I have insurance so that I can get this medication, but they don't recognize that when the cost of healthcare goes up, they pay it in premiums or in a decrease in wages because more of their compensation package is dedicated to healthcare. And so since they don't see it directly, they struggle. So I would love to kind of hear your comments on that, and also to go back to the issue of copay cards, because I don't think a lot of people know how those work.
Right. It's a great question. And it's understandable that people don't understand copay cards because they're complicated. So hold on to your hats a little bit. So fine. The pharmaceutical company and the PBM, they have negotiated a price. And typically these copay cards are for very expensive medications. Let's just use a classic one from the last 10 years, which is Humira, which was the number one selling worldwide grossing medication ever created. And so the ultimate cost to the employer or the government for paying for that Humira, let's just say round numbers, it was about $2,000 a month. Okay, so then the individual employers who are setting up their insurance plans are like, okay, well, we can't cover all 2,000 of the Humira and then make it at zero out-of-pocket cost. The patient themselves needs to be responsible for some of this. And so for those very expensive medications, typically the out-of-pocket cost was anywhere from 10 to 20%. So let's just say it was 20%. So that means that, and that was $2,000 a month. That means that the patient would have to pay $400, and then the employer would pay like $1,600. And then you add the $400 to the $1,600, and that gets you to the $2,000. Okay, well, $400 a month for a patient is a lot of money. And so a lot of patients would be like, well, shoot, I'm just like not going to fill the Humira. I'm not going to take it, or I'm going to tell my doctor, typically a gastroenterologist or a rheumatologist, to prescribe something else. So for like rheumatoid arthritis, there's another medication that's a pill called methotrexate that the American College of Rheumatology actually says is first-line treatment for rheumatoid arthritis. And so the makers of Humira are like, well, we don't want that to happen. We want people to buy as much Humira we want as many doctors to prescribe as much Humira as possible, and we want as many patients to take Humira as possible. So what we'll do is we'll create this copay card program so that when the patient goes to the pharmacy to get their Humira filled, then they will be forgiven their $400. So it will be a zero out-of-pocket cost to them. Now, we we'll only get $1,600. So we won't get the full $2,000, but I'd rather get $1,600 than zero, which is what I would get if the patient didn't fill the prescription at all. So how to get these copay cards to the patients? They came up with an ingenious plan. So there are when the pharmacist looks up on their computer, you can never see the backside of their screen, right? That's a very mysterious backside of their screen, right? And that's actually operated by another type of company called a switch operator. And the owners of the largest switch operator in America is McKesson, which is one of the largest healthcare companies in America. You know, it's a Fortune 20 company. It's massive, okay? So what McKesson did is they went to the pharmaceutical companies and they said, look, we'll let you put your coupons electronically on the screens at the pharmacy so that the patient doesn't have to go to a website or literally clip it out of a magazine and then bring it into the pharmacy. The coupon will automatically appear on the pharmacist's screen for them. So I go to my rheumatologist, I got rheumatoid arthritis, they prescribe me the Humira, I go to the pharmacy to fill my Humira prescription, and they say, oh, that's $400 out of pocket, but we've got a copay card for you that takes away that $400 out of pocket, so it will actually cost you nothing to get your Humira. Would you like to do that? Of course I'd like to do that. And instead of me then going back to my rheumatologist and are like, shoot, this medication's really expensive. Could you just do something else? Oh yeah, we could totally just do the methotrexate instead. And methotrexate's $50 a month. So because they have lowered the out-of-pocket cost for the patient, they don't ever have that conversation with their doctor around prescribing a lower cost medication. The medication still gets filled and the employer is still paying $1,600 to the pharmaceutical company to get that Humira filled. So that is a very long-winded way of saying it is a way for the pharmaceutical companies to essentially front-run the plan design that the employer has created. So the employer created this cost sharing in the plan design intentionally so that the patients would have to think about the cost of something before getting it filled. And the pharmaceutical companies are like, we've got a strategy that basically like blocks what the employer is doing. Like you can make whatever plan design you want. We're going to do an end around so that the patient doesn't even experience what that plan design is.
I love that explanation of that. And essentially, what this does is, instead of having the patient be a partner with the employer to reduce overall health spend, it is essentially tricking the patient into thinking the medication is free, or the medication is free for them. But what they don't understand is, on the back end, the cost of healthcare is actually going up, and therefore the amount, the premium that the employer is paying for them is going up, and their wages in turn are going down. If your employer is spending more on your healthcare, they have less money to give you, the employee, at the end of the day. So it's very important for us as individuals in this country who may not be a business owner to be thinking about the cost of our healthcare and the healthcare of our families on an actual, how much is it costing our employer as well as us. Because in this situation, let's say, I don't know how much methotrexate costs in cash, but let's say it costs $5 a month, which it could, $5 a month. And you pay $0 out of pocket for that. Or maybe you pay $3 out of pocket for that, right? Or maybe you pay $5 out of pocket for that. But Humira, you pay $0 out of pocket, but your employer has paid $1,600 out of pocket. And ultimately, we foot the bill, whether it's in our premiums or wages given up or in some other way that's non-transparent to us. So it is important for all people to understand healthcare finance and how we as individuals are contributing to that increase in spend and thereby our own decrease in wages. I heard a statistic on Stacey's podcast, Stacey Richter's podcast, a few days ago, that said the percent of compensation that is dedicated to healthcare, that's compensation that you don't see, but it's spent on you by your employer, has increased from 17% to 37% in the past 10 years. That's 20%. So let's say you were making $100,000 a year. That would be $120,000 a year if the cost of healthcare wasn't going up so rapidly. And sadly, that rapid increase in healthcare spend is not directly related to quality. Things are getting a lot better. You have more care, you have more access to care, you have more support. In fact, that's dwindling in many cases. So thank you for that really nice answer.
And let me just briefly say, since we're talking on an endocrine podcast, it's like at the end of the day, with like GLP-1 medications, with Ozempic for diabetes, and they, let's say that they use a copay card for Ozempic so that it's zero out-of-pocket costs for the member. Like, does that mean that we're going to start using Ozempic as first-line therapy for type 2 diabetes instead of metformin? Are we going to start doing that? Be like, no, the doctor never even brought up metformin. Why would we ever start metformin? It makes me kind of nauseous. Why would I ever want to take this metformin business? Well, shoot. Is that really a good idea? Do we really not want people ever taking metformin again because it costs pennies and has been an effective medication that's been around for decades, that many people would absolutely 100% benefit from metformin, but we're just not going to do that because we've got copay cards for Ozempic? Is that really the right thing to do? I'll let your endocrinology listeners decide.
Yeah, and I think it's a very valid question. And there are some patients with diabetes where GLP-1s are considered first line, patients with pre-existing cardiovascular disease or things like that. But I do think metformin is still a great drug, and we need to think about it, and especially when we are thinking about the employers in the self-funded space, right? So we really need to be thinking about the whole pie and how we are utilizing that pie for healthcare. And there's also other means to achieving great outcomes in diabetes that are non-pharmacological, right? Like lifestyle interventions. And sometimes in the fast-paced way medicine works now, it's like the doctor feels like they're just a prescription monkey because they have 5 minutes, and all you can really do in 5 minutes is write a prescription. You can't really counsel a patient and goal set and follow up on those goals and support the patient and give them access to and all of those things. And so that in itself, that lack of support that we are able to give our patients in the traditional setting, and actually why I left that traditional model. I do direct care and direct contracting. That also will lead to more prescribing. And absolutely, GLP-1 receptor agonists have a place, and I think the problem is that they are also too expensive. I think that if they were a more reasonable price, then we probably wouldn't be having this conversation about who should have it and who shouldn't, or who deserves it. In the obesity and diabetes world, there's a lot of talk about who deserves these medications, which is a whole can of worms that we won't go into today. But I do think there is a missing piece of patient support, patient education, lifestyle intervention, and a holistic whole approach to a person that is missing in the majority of diabetes care that is very, very powerful. We see it in our clinic every day, how impactful those interventions can be.
This, in my opinion, gets down to the issue of stewardship, because there is not infinite money. And when a physician sees a patient, like, their duty historically, and in many physicians' eyes still to this day, their duty is to only that patient. And they don't care about any other, it's referred to as an externality. They don't think about, not that they're uncaring people, but they don't even think about the ramifications of what they're doing for that specific patient. And we live in a world where that is, in my opinion, unacceptable. Like, that, in order for you to help your patients, then you need to understand the externality of how that affects other patients, how that affects your patient's out-of-pocket cost. But people are like, well, I don't want to practice that way. Okay, listen, every single doctor that practices within Kaiser Permanente has to practice that way. So are you telling me that every single doctor that practices within Kaiser Permanente is irresponsible? No, not at all. These are wonderful people that care deeply about their patients and also believe in the concept of stewardship. And so again, we're not going to answer this today on our podcast, but as physicians, we have to understand that we are stewards. And if we don't take that stewardship responsibly, then things will continue to get worse. You don't like the way healthcare is today. Part of the reason why healthcare is the way it is today is because physicians are not acting as stewards. And so if you want to be part of the solution, then we need to start acting like stewards as well.
I agree. And I also think that let's even make that a little smaller, right? Like, okay, when you're prescribing for a patient, most physicians don't even consider the financial toxicity to that one patient, And I think part of it is that there's a veil. Like, we're not taught that in training. It's difficult to find out how much things cost. Those things. It's also, we're kind of taught, hey, this is standard of care. This is what you should be doing, regardless of the costs. Like, I feel like that's how we are trained, and many physicians think about it that way. But when you take a step back, and this is what led me to start my own direct care practice, you realize that, oh my gosh, that abdominal ultrasound that I ordered for the patient to have at big hospital system X costs them $1,500, and it could have cost $75 at the imaging center down the street. And my patient can't afford a $1,500 ultrasound. That should bother us. And we should also be looking for those things, because at this point, we've all experienced it in our own lives too. And I think there's enough newsworthy material that has been out there demonstrating these massive variations in costs based on where the procedure or study is done. We need to open our eyes and recognize that we maybe doing what the guidelines say for our patients, but that may not be the most important thing to that patient in that very moment. Maybe feeding their children is more important, and maybe we have a solution that we can give them that enables them to move forward in their health and also accomplish their very real goals and tasks that they need to in their day-to-day lives.
Yeah, absolutely. And specifically for endocrinologists, what imaging study do endocrinologists order a ton of? Thyroid ultrasounds, right? And so it's like, can you order a thyroid ultrasound at an independent imaging center that would cost, a quarter to 1/6 the amount that it would cost at a major hospital system? The answer is absolutely. It might even be read by the same radiology group.
Yep.
You don't even need to have a different, and you're like, okay, well, I'm going to have multiple ones. Fine. Even more reason to have it done. And so I'm not saying don't have the thyroid ultrasound, but I'm saying you've got to be a good steward of that clinical decision.
And we have price aggregators. Like, these things exist out there. Yeah, it takes an extra step, but for imaging, we look up a zip code and find out what the best price for that particular study is in that zip code. And it gives it to us. And you're like, wait, what? I can get anything for $70 in healthcare? What is this? And so I think that it's very important for us to start thinking that way. I think that, though, now that many physicians are employed, they're encouraged to keep things in their health system. And maybe that's the final thought that we'll talk about as we wrap up. Hospital consolidation and what that has meant for the career of physicians and the cost of healthcare.
Yeah. And so overall, across, if you just average it out across the entire country and across all specialties, it's about 70% of all physicians are now employed. And of course, there'll be certain parts of the country where they're more employed than others, and there'll be certain specialties that tend to be, more employed or less employed than others. But specifically, as to your point, as it relates to endocrinologists, there are fewer and fewer private practices, whether they be private endocrinology groups or they be sort of your historical multi-specialty group that might have internal medicine and then the internal medicine subspecialty. So they'll have pulmonologists and cardiologists, et cetera. And there are fewer and fewer of those. And really the challenge has become is that once a physician becomes employed, that essentially at the end of the day, they have given away some of their autonomy, that their decision-making is no longer their own and they are dictated to by the organization what they will or will not do. And there's a very good example of a multi-specialty physician practice in North Carolina that was called Tryon Medical Partners. It's on Tryon Street in Charlotte. And they're internal medicine, but they also had endocrinologists and pulmonologists and cardiologists. And they actually separated from the large Atrium hospital system in Charlotte because what did Atrium do? They said, well, you're not having clinic nurses anymore, you're having MAs. And you're having quotas in terms of your patient, the number of patients that you need to see, and your visits need to be 15 minutes. And so they're like, look, we want nurses and we want longer visits. And Atrium said, nope. So they said, fine, we're leaving. And they left. And as a result of that, they've been highly successful. So it's not easy to do, but it really takes courage. And I'll just leave it at this. And remember that Aristotle said that courage is the virtue that allows all other virtues to happen. And so Dr. Arti, I'm super encouraged by your courage, and you have been hugely courageous, and I take inspiration from you. And so if you as a physician are looking to do what's best for your patients, just know that there are courageous physicians around America that have done just that. So you don't have to reinvent the wheel. You don't have to go it alone. There's other courageous folks out there.
Well, thank you for those kind words. And I do think it takes a good amount of courage, but also I think that when we come together, we will be so much stronger. And that's one of the big points of this podcast, is bringing physicians and patients together so that we can work together to help this crazy healthcare system that we're in, and perhaps educate physicians and patients of the the challenges or atrocities, whatever you want to call it, that have come with keeping that veil on for both non-transparency as well as hospital consolidation, and how that can drive up costs and enable us to really support each other, because the healthcare system doesn't exist without doctors and patients, right? And somehow we have sort of become this very small or very unimportant cog in a wheel type position where patients are treated like numbers and so are doctors. And we're working for insurance companies and hospital systems now. And that has led to a lot of costs that could potentially be avoided, and also a huge lapse in care for many patients. And so I think if we come together, we will truly be stronger, and we can move the needle, shake things up like we are. So Dr. Bricker, is there anything else you'd like to add? Any projects you're working on? Where can people find you? Leave us with a few final things so people can get in touch.
Thank you so much for having me, and thank you everybody for listening. And if you can go on to the A Healthcare Z YouTube channel, or you can also just connect with me on LinkedIn, Eric Bricker on LinkedIn, and I post my videos there as well. And thank you so much for having me.
Absolutely. Thanks so much for being here. And we will definitely link his YouTube channel in our show notes so you guys can find it easily. And thank you so much, Dr. Bricker, for your time. We so appreciate it.
Wonderful. Take care, everybody.